Hello, today I'm going to talk about hemorrhoids in the next chapter. So, hemorrhoids are a very common issue and problem. It's unclear exactly what percent of the population has this problem. We know it tends to occur in older individuals. Um, we do know from people that report for colonoscopy, about 40% of them have hemorrhoids, and about half of those are symptomatic. It is basically divided, hemorrhoids are divided into two classes, internal and external, based on location. The anus is about 4 centimeters long, and in the midpoint, it changes from the lining of the colon, which does not have pain receptors um, that are responsive to things like biopsy, versus the lining in the skin, which is very pain sensitive. So anything in the colon lining area that is in the 2 centimeters proximal to the dentate line, which is where the change occurs in the lining, is internal. And anything in the skin lining or in the 2 centimeters on the other side of the dentate, where the skin is starting to come in, is external. Excuse me. In general, the internal hemorrhoids are most of the time handled by gastroenterologists or non-surgeons. The external hemorrhoids, if there's going to be a procedure done, are generally handled by the surgeons. Hemorrhoids, especially hemorrhoids are basically divided into 4 grades. Grade 1 is you have hemorrhoids, but you don't know you have them. They're asymptomatic. Grade 2, you have prolapse of hemorrhoids externally, but they spontaneously go back inside, and so you may not have much symptoms there. Grade 3, you have hemorrhoids that prolapse out. They have to be manually placed back inside the anal canal. Grade 4, the hemorrhoids are out all the time, and you cannot manually place them back internally. And external hemorrhoids tend to be more symptomatic with itching and soiling and such. There are some patients that will develop a blood clot in the hemorrhoids. It can be quite painful until it resolves, and it can be relieved with incision in the doctor's office, usually surgical office, or can be other practitioners if they have experience with this. Fairly simple procedure and can give the patient a lot of relief. They also can resolve on their own. Local irritation of hemorrhoids can be treated with creams and soaks, so about 20 minutes of soaking in warm water 2 to 3 times a day. That's called sitz baths, SITZ, can help with the symptoms of hemorrhoids. Creams that are helpful usually include hydrocortisone and also can include a local anesthetic, which pramoxine is the most common that's used. Most of these are prescription items, but Tronolane is a brand name that can be obtained over the counter. Has pramoxine in it and some zinc oxide, and can be helpful and is not very expensive. Other things that can be helpful with hemorrhoids is to avoid constipation and to use stool softeners. Stool softeners like docusate sodium or docusate calcium. I think docusate sodium, the brand name used to be and is Colay still, and others. You have to be careful that you're not obtaining something that just is bisacodyl, these little tiny tablets that are more of a stimulant. You really want the stool softener. A high fiber diet may be helpful, and avoiding constipation may be helpful. Please drink plenty of water, 64 ounces of water a day. Most people go around dehydrated, don't drink that much. That will help. Of course, activity can help with constipation, and a high fiber diet, meaning 25 to 35 grams a day. And you can go ahead and look at the chapter on constipation, which has already been covered. Procedures in the office that may help for symptoms that continue. The usual one is hemorrhoidal banding. There's also infrared photocoagulation that has been used. These are the two most common office procedures that are used. Banding is what I did for many years, and there's a particular system. I use the CRH O'Regan system. This is a blind system where you don't really visualize the hemorrhoids, but you simply place 3 bands, and you place one band at a time, and there's an interval about 2 to 3 weeks between banding to allow each banded area to heal over. So basically what you do is you can do them in the office. You simply place this device into the anal canal beyond the dentate line, and you use a syringe that suctions the tissue into the syringe, and then you slide a band over it. And this works fairly well and fairly simple to do. And usually everything goes well. You try to complete 3 banding sessions, and that usually gives improvement in symptoms. And of course, this process can be repeated later if need be. A lot of times after the band is placed, there's a sense of pressure, and the patient may have to have a bowel movement. Of course, with any procedure, there can be complications such as bleeding may occur, may require treatment. Urinary retention can occur, requiring a bladder catheter. The band may cause a lot of pain and may have to be removed in the office before the patient leaves, and then placed a little bit further in. It could be that the band is actually affecting a part of the skin area, and that's giving the patient pain. So that may have to happen. And then infection is also less common occurrence after banding, but can be disastrous. So if that occurs, you have to, I think, jump on that right away. Most likely admit the patient to the hospital, give antibiotics, and follow closely, that sort of thing. So, generally speaking, I did a number of these, never had an infection. We had one patient that said he had some bleeding and then had to be treated. Someone else treated that while perhaps closer to where the patient was located. And then didn't have to have, there may have been one patient that had a urinary catheter bladder, but I'm not sure. I can't recall for sure on that. But generally it went well and was helpful. Of course, there are some patients that will need to have surgical procedures under anesthesia for more complicated cases of hemorrhoids, but those procedures that they do can be quite helpful. But there is a recovery and more pain with such procedures after the procedure is accomplished. So those are generally handled by surgical service. Now with hemorrhoids, you have to be sure on your diagnosis is that what you're dealing with. And so generally speaking, you want to make sure the patient's had a colonoscopy if they need a screening, or if there's any question about the bleeding and you're not sure it's from hemorrhoids, would have a very low threshold of doing colonoscopy and checking the colon to make sure there's not some other bleeding site like colon cancer. People can also have colon cancer and also have hemorrhoids together. It's not an uncommon occurrence to have both of them. And it could be that the patient has hemorrhoids, but they're not what's bleeding. The bleeding is coming from higher up, and it's colon cancer. So you have to be very careful and make sure your diagnosis is correct. And generally, I would do a colonoscopy just to make sure there's nothing else going on. before doing a procedure like a hemorrhoidal procedure. Unless, of course, the patient's just had a recent colonoscopy or recent evaluation. So with that, I'm going to go ahead and stop, and thanks for your attention.